are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number 2. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our MedEClasses, which was our online portal, which takes it beyond the routine classroom to beyond so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines, plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the MedEClasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working was like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was an Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there. And you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us. Now, precocious puberty is common in girls more than boys, but it is more likely to be physiological. Delayed puberty is more common in boys, but again more likely to be physiological. So if you have a boy with precocious puberty and a girl with delayed puberty, you are more concerned about the likelihood of a pathology. So precocious puberty in girls is defined as a pubarchy or thelarchy before 8 years of age and vaginal bleeding before 9.5 years of age in that regards. Look at the extent. If there is only pubarchy, look at DHEAS. If the DHEAS is low, this is only pubarchy, nothing much to worry. 40 to 135, look at adrenarchy. More than 135, look at CAH as a possibility. Only vaginal bleeding, normal breast, normal pubic hair, think of a local cause. Trauma, tumor, abuse. If you have complete puberty, thelarchy, look at the bone age. And if the bone age is retarded, think hypothyroidism. Normal, look at slowly progressive, and advanced, look at LH. And then you can decide. Now, these are so many parameters to look at. We have tried to simplify it using a puberty interpreter, which will really look at only a few parameters to give you a diagnosis. I'll invite Dr. Sandeep to join in as well. So we have a 2-year-old girl with thelarchy, onset 6 months ago, slowly progressive. What do you think is happening here?
So this is 2 years old girl and thelarchy has happened and slowly progressive. So we should investigate further, sir.
So breast is stage 3, pubic hair is 1.
So this can be isolated thelarchy, sir.
And the height is also normal. So you want to further work up or you want to wait for some time?
Sir, since there is only breast development is there and there are no signs of macronucleate also, sir, there are no capillary spots, then we can keep the patient on follow-up also, sir.
We can keep on follow-up or do a baseline workup in that perspective. So if you look at our interpreter, what it's saying is that you have to do the basic workup and then you can decide from that. Most likely this will be a slowly progressive puberty. So this is a slowly progressive puberty. You don't need to do much. What about this girl?
This is 6-year-old girl, sir. She presents with thelarchy since 1 month and height is 124, sir.
So you think she has true precocious puberty?
We need further input, sir. Like
Clinically, she is stage 3, she is 6 years. So this is most likely a rapidly progressive. She is tall also for her age. So if you look at the other parameters, bone age is 11 years. So this is definitely
most likely pathological progressive puberty, sir.
Progressive puberty. So if you look at our analysis based upon the height and the bone age, we will find that we need to do workup in that perspective. So clearly the guidance would be based upon the bone age. Now, how do you define as advanced bone age? What is advanced bone age?
Sir, bone age more than like 120% of the
height age. So if bone age is more than 120% of the height age, this is suggestive of a advanced puberty. Or I would say height standard deviation score, which is for bone age, which is less than -2. This is an important pointer. This girl at 6 years is not short. Her height is 1.74. But when you correct for the bone age, it becomes -2.64. So this, I would say, is the most important parameter which will help you out in terms of treatment. So the interpreter is saying that you would need to start treatment from that perspective. 6-year-old girl with pubarchy, birth weight is normal. Carry on.
The birth weight is normal and she presented with pubarchy. Height is 132. Weight is 26 kg, sir. Pubic hair stage 3, breast stage 1, and there is no menarche.
So do you think this is significant or not?
Puberty stage is significant, sir. Each level is 3.
So up to stage 2, you may not worry. But if it's going 3 and beyond, this is definitely worry in that regard. So do you think this is just pubarchy, adenarche, or exaggerated adenarche?
So we have to investigate the patient, sir.
Okay. And so clearly, if you put the pubic hair and other parameters, it's saying likely precocious pubarchy. You have to do DHEAS, which is very, very important here. So DHEAS is 240. Testo is also high. So what do you think?
The DH is high and testo is also high. So we should go for 17 OHP and imaging, sir.
So we have to rule out a possibility of a adrenal pathology.
7-year-old girl presented with vaginal bleeding and that was only 1 episode. And the pubertal status is B1 and PH1.
So what do you think?
So only bleeding with no breast development and pubic hair is more like it's likely a isolated vaginal bleeding, sir. And the vaginal mucosa is also red, so that there is no estrogen exposure.
So if you say B1, P1 and periods, it is most likely isolated bleeding. You have to go for a gynecology referral in that perspective. Yes. Now, 7-year-old girl with thelarchy, do you think this is significant, this girl?
The thelarchy is significant, sir.
Okay, and the other thing we are looking at?
Her height is 100, which is like short, sir. Short for her age.
And she very recently had a vaginal bleeding as well.
And the breast stage is 3, pubic hair stage 1, and mucosa, the vaginal mucosa is pink.
Okay, and this is the growth chart.
Growth chart, she's significantly short as for her age, and the weight is not that.
So what do you think? 7-year-old girl with menarche, thelarchy, very short, and this is the growth chart.
So, sir, she is having height is less for her age and for the level of puberty. And so we should investigate for thyroid functions.
So all girls with precocious puberty should be tall. This is a short girl. Think thyroid. There's a large ovarian cyst putting there. So this is a von Wieck-Grumbach syndrome, which is because of the effect of
TS is on the FSH receptors.
Yes. So this is clearly bone age is delayed. If you look at our app, put the data in terms of breast. And why is there no pubarchy?
So because this is the local effect of FSH on.
Because TSH is high, TRH is high, prolactin is high, LH is low. So high FSH, low LH. So no pubarchy. And of course, bone age is delayed. How can you have pubarchy if the adrenals will not wake up at all? So this really based upon these parameters gives you consider hypothyroidism as a possibility in that regards. Now, management, of course, depends upon the age. Less than 6 years of age, most central will require treatment. 6 to 8 years, depending upon bone age, you will treat. You can think of GnRH analog, which if you give on a long-acting one, will desensitize the pituitary. And this is how it will work. The other option, of course, will be that you have to be very careful in terms of adherence. So if there is a gap between treatment, then you will have again recurrence which is happening. And we discussed about the monitoring. What is the best way to monitor according to you based upon the discussion we had that day?
Sir, for the best way is to look for clinical parameters like sir,
Yes.
bone age and the
Mhm.
pubertal status, sir.
Mhm.
And apart from that, we can go for the basal LS level, sir.
So basal LH or the LH 2 hours after the
After the
injection,
injection of
the agonist injection,
yes, sir.
the random LH doesn't have that much value in that perspective. So you expect an improvement in the breast development, improvement in bleeding, but not much improvement as far as pubic hair is concerned. Medroxyprogesterone acetate is one agent which can be considered in which group of individuals?
So those patients whom we are not worried about the pubertal status, we are worried about the bleeding, like patient with cerebral palsy.
So where the height is not a major issue, then you can give MPA only for a vaginal bleeding perspective. So we have got all the therapeutic options and details which are given as part of the app. Now in boys, we know that if you have an onset of puberty before 9 years of age, that is the early puberty, and the testicular volume will give you a cue. Both testes are enlarged, you are talking about central precocious puberty. If there is both testes are small, this is peripheral. If both are intermediate, which mean that the Leydig cells are big but the Sertoli cells are not big, this is HCG dependent or a LH receptor problem, and one is big, this is more likely to be a testicular tumor. So this is a 4-year-old boy with early puberty with large testes. Do you think this is pathological?
4 year with large testes with early puberty is pathological, sir.
So boys anyways have a very high chance of pathology. So if you go by our own guideline, it will say that this is central precocious puberty and recommend MRI head. Now, if you go to our algorithm, then you go to the interpreter. If the girl is below 6 years, we would say do a MRI. After 6 years, only if the neurological features are there. But boys, every boy should have a MRI. What do you expect here in this MRI?
So for this level of puberty at this age with large testes and the LS level is high, sir. So it is likely hypothalamic hamartoma is there, sir.
So the most common cause of very early onset precocious puberty is the hypothalamic hematoma, which is an abnormal location for a normal tissue. So it's a ectopic location of hypothalamus, which is not being regulated. Would you send to the neurosurgeon? This looks a very large lesion.
So there is no need of neurosurgery as such, and we should start with the generous agonist treatment, and we should keep the patient on the follow-up.
Unless it's 8 centimeter or above, it's causing some pressure symptoms, you don't need to do any surgical intervention. 7-year-old boy and the testicular volume is less in that perspective. And what do you think here?
When the testicle volume is less and there is early puberty, then it's most likely going to be a peripheral one, sir.
So this is most likely a peripheral precocious puberty. And in this scenario, your LHFSH is low, testo is very high. Which next test will you think of?
So then in this scenario, we should go for 17 OHP, sir.
So of course, 17 OHP becomes important because adrenal cause will be there. Look for blood pressure, look for pigmentation. So there is an adrenal hyperplasia, and always think of an adrenal tumor because that's also something you can be aware about. Can you have high 17 OHP in adrenal tumor?
Yes, sir, we can have, sir.
Adrenal carcinoma can have some elevation in 17 OHP, not this high, but yes. Don't just get misguided. Your 17 OHP is 10, 15, 20, that this is only CAH. Think of it could be adrenal lesion also. And we have missed patients with adrenal carcinoma. They may be indolent. They may have no other features other than precocious puberty. And then they will come to you with frank metastasis. So delayed puberty in girls is defined as breast which is not happening by 13 and menarche within 5 years. The workup basically determined based upon the screening test first. You have to exclude all the chronic systemic illnesses and then gonadotropin levels. If they are high, we are thinking of Turner syndrome. If they are low, we are thinking of a central pathology from that perspective. So you have a 16-year-old girl with delayed puberty, no breast, no pubic hair. She is short and she is lean. What are you thinking about?
So at 16 years, no puberty, breast stage 1, pubic hair stage 1, and she's underweight, sir. So we should look for the systemic causes, sir.
So before you do any unnecessary workup, LH is low, but it is expected to be low because your nutrition is not there. So if you look at the evaluation, you have to think of first systemic causes, and one important cause here would be TTG, which we identify, and she had anemia, clubbing, and happened to be celiac disease. 16-year-old girl with primary amenorrhea, a very typical scenario, stage 4 breast, no pubic hair. What do you think?
So, sir, 16 years old girl with primary amenorrhea and there is breast stage 4 with no pubic hairs. So, we should look for androgen insensitivity syndrome can be a possibility.
So if you look at primary amenorrhea, look at breast. No breast, that is delayed puberty. Breast development with hirsutism, that is PCOS. Breast development, no pubic hair, that is androgen insensitivity. And breast development and normal pubic hair is a local cause, like Mullerian agenesis. So stage 4 breast development, she is tall, FSH is high, karyotype clearly in this scenario is going to be XY. This is a classical case of androgen insensitivity syndrome. So our app will give you a diagnosis in that perspective. For boys, delayed puberty is no testicular enlargement by 14 years or stall development. There is no role of pubic hair or penile length. Remember, boys usually are physiological. So 80% will be CDGP. Your main aim is to think of when this is not CDGP. So if you have a tall boy with pubic hair development, CNS feature, micropenis and stalled puberty, this is not CDGP. Then of course workup depends upon your testosterone levels and gonadotropin levels, and then you differentiate constitutional delay versus permanent HH using your testicular volume and inhibin B. This algorithm which we have put here is used as far as our interpreter for puberty is concerned. Mainly we are looking at TV and inhibin B. TV less than 1 ml, inhibin less than 50, think of permanent HH. TV more than 3 ml, inhibin more than 100, this is most likely a self-limited form of delayed puberty. So 16-year-old boy with pubertal concern, onset at 13 years, then stopped for 2 years. So do you think this is CDGP?
No, sir, this is not a CDGP because this is stalled puberty.
Yes, and the child is tall also, testicular volume is 1 ml, has pubic hair. So this is everything which is going against the diagnosis of CDGP. So this, if you look into our own application, what it is telling us is that this is most likely going to be a permanent HH for which you need to work up from that perspective. 17-year-old boy with pubertal concern, also at 12 years, now stopped for 3 years, testis is 2 ml infirm with gynecomastia, height is 182 centimeters. What do you think? A tall boy with gynecomastia?
Testis and stalled puberty. So it is going in favor of Klinefelter syndrome.
So this is a classical picture of Klinefelter syndrome. And again, FSH is high, karyotype is XXY. So this is classically Klinefelter syndrome. So this is the puberty interpreter, which we have been showcasing for both boys and girls, including delayed puberty, precocious puberty, everything is evaluated, and we found a very good score in terms of validation for this. Now, more people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous grow, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MedEClasses Endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.